Good morning and welcome everyone to this week's Insight APSAD webinar. I'd like to begin this morning by acknowledging the traditional owners of the lands on which we're all meeting, to pay my respects to elders past, present and emerging, and also to extend that welcome and respect to any Aboriginal and Torres Strait Islander peoples who are joining us either in the room here at Biala or out there in webinar land. So my name's James. I'm one of the clinical educators here with Insight. And thank you for coming along and joining us this morning. And for those of you who have been maybe following our webinar calendar for this semester, you would have noticed that we have a number of these sessions dedicated to the introduction of the QScript process. That's a number of things. It's legislation, supporting real-time prescription monitoring. It's also about some of the technical components in terms of the solution that is going to be the, I guess, the management side of things. But also, I think really importantly, and probably why a lot of you have tuned into this particular discussion today, is also to make sure that the introductions of those types of processes don't in any way take away from good treatment. And today is about looking at treatment pathways going forward under these types of introductions of systems and processes and legislation, to make sure that the focus does remain on providing optimal support to the people that we're working with. And for that reason, we fantastically have some great speakers presenting. Some of you may have come across Tony Hall previously, who is a Senior Clinical Pharmacist down with the Persistent Pain Clinic at the Gold Coast Hospital, and I see Tony's online there. And Tony is also a Senior Lecturer at QUT, so we very much welcome him speaking to us on this topic, and he'll join us shortly. And we also have Dr. Ian Thong, who is a neuroscientist and a pain medicine specialist. Now, Ian, due to emergent needs, isn't able to be with us live today, but he's very kindly recorded his part of the presentation this morning. So the way we'll be running things is that Tony will jump on in a few moments and begin our webinar session today on this topic. And then once he's finished, we'll move over to the recording that Dr. Thong has kindly sent to us so that he can speak from his experience on the management of this nexus between pain and opioid use and optimal care. And feel free at any point to pop your questions into the chat. We'll review those as the webinar is proceeding today and spend some time at the end presenting as many of those as we can to our presenters. We also have some other people here supporting us today who can be referred to. We have Vivian, who's also a colleague and a pharmacist with Tony down on the Gold Coast, and we have Nicolette, who's also here to help us with any specific QScript situation or solution type questions as well. So welcome everyone, and welcome everyone who's tuned in as well. So without any further ado, I'll now hand over to Tony. Thank you, Tony.
So there's, again, just again to acknowledge the traditional owners on the land on which we're holding this teleconference, and to pay my respects to elders past, present and emerging. So what I've been asked to do is to talk about persistent pain, opioid use disorder. Are they both the same? Are they overlapping in some way? Okay, so some of my talk will be aimed at the environment here in Queensland, and for those outside of Queensland, I apologise for that. This is looking at the opioid crisis, and I use the word crisis with some reluctance because I think that it's become very politicised. Yes, we have a problem. No, we have nothing like the problem that was faced by the US 10 years ago. So here we see drug-induced deaths in Australia increasing steadily over time, and now overtaking that of both road traffic accidents and both motorcycle and car. But a lot of these are unintentional. This is looking at the unintentional drug-induced deaths from opioids, and we can see that prescription opioids are now have just eclipsed those associated with heroin, but are on their way down. And as we can see, there's a fentanyl, pethidine, and tramadol do have a significant element in there. Pethidine and fentanyl, rather, in particular. So this is looking at prescription opioid death rates per 100,000, with Queensland is in the green compared to other states. This is a lighter coloured green. Western Australia, as we can see here on the first one here with oxycodone, morphine, and codeine, is actually higher than Queensland. Queensland sort of in there with the rest. It's been jumbling up and down since around about 2000s. The government thinks that the work they have been doing through the TGA has actually made a reduction. The evidence is equivocal on that. Looking at also fentanyl, pethidine, and fentanyl is by far the biggest risk agent.
It was working, and then now I can't even hear him.
And methadone is there steadily all the way through. This is looking at opioid prescribing in Queensland. We can see that the numbers of patients has been increasing steadily over time. The majority of these patients are still on what we would class as low dose opioids. That's less than 50 milligrams of oral morphine equivalent a day. The opioids include all the normal ones: morphine, oxycodone, hydromorphone, fentanyl. Unfortunately, it doesn't include tramadol data in that figure. Methadone was deliberately excluded as being unable to distinguish between use in persistent pain and also in ORT. The findings indicate that most Queensland medical practitioners now prescribe lower opioid doses and there's been an increased proportion of these patients since 2004. The proportion of patients dispensed doses of opioids more than 50 milligram has been associated with an increased risk of accidental overdose. And this is small and has actually declined over time. In terms of unintentional deaths by age and gender, we can see that the high-risk groups are actually those that are most affected by persistent pain. That group in the late 30s and 40s, and then diminishing as patients age. It doesn't mean to say that persistent pain diminishes with age, it's just that our individual patients seem to complain about it less. And as we can see, there is a greater use of pharmaceutical opioids than heroin, but heroin is certainly present even into our older age groups. And as we can see, that males have a greater tendency for drug-induced death than females. And pharmaceutical opioids has a major component in both of those. So we've certainly got a problem with pharmaceutical opioids, but I really don't think we can possibly describe it as a crisis. This is the crisis in the US, and there was this massive increase in opioid prescription, which peaked in 2011 and has been a steady decline since then. The biggest problem associated with the death rate associated with that crisis was related to heroin, which had been spiked with fentanyl, and also to the increased use of illicit fentanyl being used by addicts at that time. And they concluded that many of the current assumptions were ill-founded, and national discussions about the opioid crisis often neglected the potentially devastating effects of uncontrolled persistent pain. So why do patients die from their opioids? Well, the most common one is the loss of tolerance. Patients taking larger doses are then followed by a planned reduction in that dose, and that then when they may cease their opioids, and then their pain starts to spike, so they go back to their opioid prescription again, and often start on the very large dose that they were on previously. So here was a case that was actually in the coroner's inquest I attended about 2 years ago now. 46-year-old male, previously taking 100 micrograms of fentanyl patch, about 360 milligrams equivalent of morphine, had been successfully deprescribed down to oral morphine in a dose of 20 milligrams twice a day. But a breakdown in the supply mechanism led to that patient reinitiating his fentanyl patch. He happened to have a patch available to him at home, and he experienced an accidental overdose because of the dose that he was now taking of that fentanyl. And we do have this risk of what was being described as opioid depots in the community, the unused prescription opioids kept by families or friends just in case. And at a conference I attended about 3 years ago now, we put the then president of the Pharmaceutical Society, Hospital Pharmaceutical Society in Australia, and the medical director of the TGA on the spot, and they both admitted to having a box of oxycodone 5 milligram tablets in their medicine cabinet at home, again, just in case. So we do have these depots lying around, and this is what happened to this male. He went back to his depot, but then got the dose completely wrong. We can have alterations in administration methods. We do hear a lot about patients who change their controlled release opioids into instant release by destroying the controlled release mechanism just by breaking the tablet. I had someone yesterday who broke the tablet into quarters, but hadn't realized that by doing that, they'd actually destroyed their controlled release mechanism, and they wonder why it didn't last as long. Changing the route of administration, for instance, making the injection from a solid dose increases the viability of that very same dose by about 50% in some cases. And also reduction in nociception will also change the pain-induced respiratory drive, and that can lead to increased respiratory suppression. So what about by location? Well, we do see large numbers of these unintentional drug overdoses occurring in capital cities. But as I'm going to show you now, that we've actually got a higher rate emerging in rural sectors. This is by states. So Queensland is up there in the middle, much bigger problem than for instance, Tasmania, Northern Territory, and Victoria, but nowhere near as big a problem as Western Australia. And so that's because this is the Australian Atlas of Healthcare Variation, looking at opioid prescribing by area, and the darker the blue, the heavier the prescribing per capita. And as we can see, the rural environment is where we're getting the biggest problems. And there's one here for where we are down on the Gold Coast and where you are in Brisbane, with the very, very heavy prescribing of opioids in the more rural Western areas, and also into northern New South Wales. And we cover northern New South Wales here from the Gold Coast, because the next persistent pain centre going south is a small one in Lismore, but the next one is down at Coffs Harbour. So we tend to draw large numbers of patients who, when they're able to cross the border, we draw large numbers of patients in northern New South Wales. So let's just clarify some definitions, and I think these are ones which are common to all of us. Substance use disorder, a disease that affects an individual's brain and behavior, leads to an inability to control the use of a legal or illegal drug or medication. And these are substances such as alcohol, marijuana, nicotine, but also opioids would come into that group as well. A person diagnosed with a substance use disorder uses a particular substance regularly, and over time they may build up tolerance, meaning that they tend to take larger doses of something to get the same effect. They'll probably find it difficult to stop taking the substance because the long-term regular use can lead to pretty unpleasant withdrawal effects in many people. Opioid misuse, opioid use, contrary to the directory or to the directed or prescribing patterns of use, regardless of the presence or absence of harm or adverse effects? What if that direction or prescription is wrong or inappropriate? And we see a lot of that coming through in the pain practice, where the regular use of short-acting medicines used either regularly or when required is probably now inappropriate compared to the use of longer-acting medication, and I'll talk more about that in persistent pain. Opioid abuse, the intentional use of the opioid for non-medical purposes. We do see cases in the persistent pain clinic, but it's been estimated that that only accounts for 3 to 5% of patients attending this clinic are seeking our input into their access to opioids for non-pain purposes. And opioid addiction, a pattern of continued opioid use associated with experience or demonstrated potential for harm. So where there's impaired control over drug use, compulsive use, continued use despite harm and craving. We both talk about dependence, and there are really 2 forms of dependence, and they may overlap. Psychological dependence, which is a chronic relapsing disorder that affects physical and mental health, social well-being and function. It's a complex biopsychosocial disorder where the individual feels a loss of control over the use of opioids. They continue regular and often heavy opioid use despite health, legal, and relationship problems. Some harm may occur from any drug use, but problems, particularly dependence, are more common with regular use over long periods of time. And not everyone who takes opioids, even long-term, develops psychological dependence. Pharmacological dependence, where the regular use of a medication can lead to the production to a reduction in the production of endogenous opioids. So for instance, with the regular use of opioid analgesics, this reduces into cerebral levels of enkephalin and endorphin. The sudden withdrawal of an opioid can then lead to withdrawal symptoms. And everyone who takes an opioid, even for a term as short as 2 weeks, can develop that pharmacological dependence. So I've seen numbers of patients post, for instance, surgery, who go into a withdrawal process when they stop taking their opioid analgesics used even after just a short period of time. Drug diversion is a medical and legal concept involving the transfer of any legally prescribed substance for an individual to whom it is prescribed for another person. And it's a common problem where someone will share their prescribed medicine with a family medicine with the, and I put this in parentheses, the same condition. And it commonly includes things like benzodiazepines. You know, their relative has trouble falling off to sleep, so their relative will offer them some of their prescription medicines to use to help them over that problem. And we see the same thing with the opioids, with the stimulant medicines used, for instance, normally in the treatment of ADHD, and also with the Z drugs, the zolpidem and zopiclone prescription medications as well. So prescription of medication, I think we need to be aware that we have 2 environments that we talk about, particularly in healthcare. As an inpatient prescription is actually not a prescription, it's an authority for the administration of medication as interpreted by pharmacists and nurses. Now, when we say, for instance, twice a day, that is interpreted usually by us in healthcare as we have 1 dose in the morning, 1 dose in the evening. And when required means when necessary to manage a particular sign and symptom. And there are systems in place to monitor and correct where misinterpretation may occur. So the purple pen, which the pharmacist may annotate the inpatient prescription medication record with, was a way of helping the nursing staff and others to administer these medications more appropriately. And we keep scrupulous records of administration. So every single dose of an S8 medication, which is prescribed and delivered to a patient is recorded in CD registers by both the hospital pharmacies and also for the individual dose on the individual wards. However, we need to then think about what happens in the community. So in the community, a patient is given a prescription which is the authority for that patient to self-administer medications as intended by the prescriber, but as interpreted by the patient. And that may not be the same as we see within the inpatient. So twice a day could be interpreted as, well, 2 times in the day. And that could be when I'm in greatest pain, which is, I've got musculoskeletal pain. So when I'm up and moving during the day, my pain is worse. So I'll take it morning and in the afternoon. But I then, in many patients' situations, they then suffer because their sleep is disturbed. And when required, which is often used for the instant release opioids, is when the patient believes it is necessary. But once the medication enters the patient home, there is little or no supervision or record of how these medications are actually taken. And it's the appropriate use of medicines is key to the self-management of most chronic diseases, including persistent pain. And over 30% of prescribed medication is not being taken as intended, and that would be classed as non-adherence to medication. And non-adherence is a common problem within healthcare. We must understand that there are the health psychology models which enable us to understand the complexity of the relationship of medication use in the community, includes social cognition models such as the health belief model and theory of planned behavior, and also self-regulatory theories that share the assumption that individuals develop beliefs that influence their interpretation of information experience that then guide their behavior. So we also need to consider in this context compliance, adherence, concordance. Compliance, the extent to which a patient's behavior matches the prescriber's recommendations. Recommendations then may be different to instruction. However, its use is declining because it implies a lack of patient involvement, and with patient-centered care, we're beginning to use the terms adherence or even concordance. So the adherence, the extent to which the patient's behavior matches agreed recommendations from the prescriber. And that's really what your instructions as a prescriber, the instructions on the prescription are really seen just as recommendations by the patient. It's been adopted by many as the alternative to compliance, as it seems to emphasize that the patient is free to decide whether to adhere to the doctor's recommendations, and that failure to do so should not be a reason to blame the patient. Now, think about that in terms of the way that we often blame the patient for not following the way that the prescription was written. And adherence develops the definition of compliance by emphasizing the need for an agreement in that process. It's how often do we actually seek agreement following the prescription. So we need really to think about the education and trying to get agreement as how these medications should be used. And that rarely happens in prescription. So concordance is a relatively recent term. It's used predominantly where I come from in the UK. Definition has changed over time from one which focused on the consultation process, in which the doctor and the patient agree therapeutic decisions that incorporate their respective views, to a wider concept that stretches from prescribing communication to patient support in medication taking. And it's sometimes used incorrectly as a synonym for adherence. So as soon as a medication enters the patient's home, healthcare, which is you and I and our medical colleagues, lose control of how medications are actually being taken. And a friend of mine, Rob Horn, who did his PhD in this area, identified 3 major factors which influence that maintenance of medication as intended within healthcare. And he thinks that there was belief necessity and concern. And there's a balance between those. So the beliefs of the patient, the necessity of taking the medication. For instance, there are some situations, for instance, hypertension, where there are no symptoms associated with an increased blood pressure, but we hope that patients will take their medications regularly to try and reduce that blood pressure to keep it within more agreed normal means, compared, for instance, with asthma. And asthma will, many patients will just use their asthma puffers when they get short of breath, where there is a sensation, a symptom which they can identify as associated with the asthma attack. The concern, most patients, 89% in the evidence in the literature, believe that their prescribed medication is necessary to maintain their health, but may be concerned about the risks they take by taking a medication. And a good example of this is what we're seeing currently with vaccination hesitancy. Oops, sorry. Many people can see the benefits of getting vaccination, but they're worried about the risks that the particular vaccines might hold for them, and that's making them hesitant in getting vaccinated. Non-adherence can also be described as rational as well as irrational, is often based upon the beliefs and motivations of the patient. So, for instance, when we talk about analgesics, often the terminology used is painkiller, and that may reinforce the belief that analgesics will actually remove, kill, cure pain. And I have to tell patients almost every day that unfortunately no analgesic has been invented that will take away, reduce to zero, persistent pain. So rational non-adherence can include cessation of a medicine that is making the patient feel unwell. So commonly I see patients taking an opioid and the patient experiences nausea, occasionally vomiting, and certainly constipation. And for many patients, those side effects are pretty unpleasant, and that will then cause them to stop taking the medication that's being suggested for them. 50% of patients taking an antidepressant for major depression will be non-adherent, will stop taking that medication within 3 months of initiation. And rates of adherence in more serious mental health conditions like schizophrenia are only 50 to 60%, and about 35% in bipolar affective disorders. So we need to be very careful about the language we use in terms of describing medications to patients. Non-adherence can also include taking additional doses as opposed to not taking a medicine. And in terms of gender, males are often higher in this concept of, it's almost like they have a poorer acceptance of risk, so they don't see there's a risk in taking more of the medicine than is being recommended. And we're also seeing the same in younger patients who are perhaps more willing to take risks. Health literacy is becoming a significant issue which is being addressed within the Australian healthcare system, and certainly I was looking at health literacy as a major topic within our health service, and we're being encouraged to consider health literacy and the way patients interpret and can. But it's not just literacy, it's not just reading something. We also have to include within that numeracy, but also it's that overall understanding of healthcare and how to access and use the complex healthcare situation which we're faced in Australia. In terms of medication-related literacy, it's complicated by the number of prescribed medicines. We use the term polypharmacy to describe situations where more than 5 medications a day are being taken, and the term hyperpolypharmacy when that is more than 10 medications a day. Now, in an audit we conducted last year, the average number of medications being taken with patients coming to the pain clinic was 12. We saw very few patients who were taking less than five medications. That is also complicated by not just the number of prescribed doses every day, but also the different and the frequency of which those medications need to be taken. So we know that patients are better able to take medicines once or twice a day than they are 3 or 4 times a day, but also the different routes of administration. So complexity of treatment regimes can also lead to forgetfulness, which is the non-volitional non-adherence, as well as where there's a cost and benefit involved. So, you know, patients often have to pay, certainly in Australian healthcare, they have to pay for medications. That then produces a financial burden. The more medications they have to take, the bigger the burden, and they then have to prioritize that with their other life factors, and this can lead to a volitional non-adherence. As well as then that's influenced by the therapeutic relationship between healthcare provider and patient and a history of previous non-adherence. And that therapeutic relationship is often what we hear being described significantly within our community health situation, where, you know, many patients cannot expect to spend more than 5 to 6 minutes with their GP at an individual consultation. What can help with this situation? Well, although identified as a relatively weak agent to achieve change, patient education is considered the most important factor to improve adherence. And I think what we need to be aware of is that we do not spend enough time educating the patient on how to use the medications that they are being supplied with. Patients are often reluctant. I mean, I teach pharmacy students, and they're taught how to engage the patients in consultation when their medication is being dispensed, but they come back and say, well, in practice, few patients actually want that. They seem to want to go and get off quicker. Simplification of the medication regime is difficult in modern medicine because many patients are often multiple prescribers. One of the key things that we believe in the pain clinic here is that we do not prescribe medications for patients. The GP is the sole prescriber of the medications we use in persistent pain. A couple of exceptions would be gabapentin and lignocaine patches, which are not on the PBS. And if we want them to be used, we often have to supply them ourselves because of the cost burden that's then faced by the patient. But many patients have got their GP, they've got specialists that they see both in the hospital, but also in private practice. They're seeing perhaps UNARs, they're seeing psychiatrists. They may be also seeing a physiotherapist who is advising them on the use of, for instance, over-the-counter non-steroidal anti-inflammatories. Many very complex situation. Each of these individuals may be making their own play to provide medications. What we may need to do, and we see that commonly in the situation here, we may need to de-prescribe, where we argue that there needs to be a prioritization in the health conditions made so that we can then reduce the number of medicines being taken. And in pain medicine, we try and maintain the GP as that final single point of priority. And we also try and maintain a single supportive supply. So encourage patients to just get their medications from a single pharmacy. Single pharmacy use is higher in older patients, but in younger patients, it's the nearest at the time of getting the prescription. What does not work well are dose administration aids. They may help where non-adherence is directly related to memory and forgetfulness, but they can also lead to 100% non-adherence if the patient forgets to use that dose administration aid. And draconian prescribing rules may actually drive patients to access medications through the black market rather than through the healthcare system, which we are trying to promote. So the term pseudo-addiction was introduced in '89 to describe single case report, 17-year-old male with leukemia who was prescribed intravenous morphine for pain, but received no extra doses. And after a few days, the patient started displaying behavior which we associate with addiction: moaning, crying, complaining, trying to elicit doses. And the authors argued that this was because medically we were under-treating their pain. We were giving an insufficient dosage, and the dose interval between those doses, certainly at 6 hours, would be considered excessive. So we are now forcing patients into a cycle of pain and then pain relief, and then the pain comes back. So it's an iatrogenic condition caused by withholding or under-treating pain, often combined with unrealistic expectations of what these medicines will actually achieve. And I think one of the big failures in healthcare overall is that we fail to provide a goal for the treatment. Now, many of us would think that would be self-obvious. So for instance, I get a prescription for an antibiotic, surely it's to cure my infection, and that's absolutely true. But what about for persistent pain? When no analgesia will take pain away, what is the best that an analgesic medication can achieve? And that's probably a 50% reduction in their pain score. So what we need to make clear to patients is that no medication is going to take pain away. So there's no point, and no dose of that medication will take pain away. So there's no point in increasing the dosage, searching for that, or going back to the GP searching for other drugs that can be used, because they don't exist. What we're aiming for is optimal pain management, which is keeping pain at a bearable level. And that translates in practice into a pain score of about 4 out of 10. Now, if we can maintain pain scores of 4 out of 10 or less, 24 hours a day, 7 days a week, 365 days a year, that's really what we're aiming to try and achieve with the use of analgesics in persistent pain. Modern proponents of the opioid crisis have also connected this with the introduction of pain as the fifth vital sign. He said by focusing upon pain, we're now focusing on managing that symptom. Now, in 2014, pseudoaddiction was discussed in 224 articles. Only 18 contributed to or questioned the phenomena from a theoretical perspective, and none of them empirically tested or confirming that's experience. So the use of this phrase probably has decreased, but we still need to understand that there can be an under-treatment or inappropriate treatment of persistent pain. And this is a phenomenon we observe in the pain center on a daily basis. The use of, when required, medication for persistent symptoms in a chronic health condition, the use of opioids for pain, which has been shown to be opioid non-responsive, the use, for instance, of gabapentinoid patients for pain, which is not neuropathic in nature. It's often nerve-related, but that's not the same as neuropathic. And the use of non-steroidals in pain where there's no inflammation. Substance dependence, you know more about this than I do, but many of the definitions are actually associated with the normal pharmacological activity of opioid analgesics. So tolerance will always develop. Patients taking opioid analgesics, it's a pharmacological effect. Withdrawal will occur because we are withdrawing opioids at times, particularly in between doses, for instance. The fact that problematic drug-related behavior can be driven by poorly controlled pain and extinguished with adequate pain control becoming a fundamental rule of opioid therapy, and has been extended to include behaviors such as excusing the co-administration of cannabis for pain or symptom control. So how do we manage aberrant drug behaviors? So while physicians should always work to believe their patients' self-reporting and pain and respond with interventions aiming at optimizing patient control, aberrant pain drug-related behaviors must also be addressed. So we need strategies that help the patient optimally adhere to their medication regimes. Simple dose escalation is not the sole response. elimination of when required treatments and the regular use of longer acting medications is often the way we deal with it. And we certainly really spend time looking at pain education, explaining to patients, well, while we can't eliminate pain, we're trying to achieve long pain management. Then you also got the term chemical copers, introduced by Kirsch in 2007 in persistent pain to describe the middle ground between compliant and frequent and severe aberrant behavior associated with opioid and anxiolytic medication use. And it describes non-adherence of the use of medications to cope with stressful scenario. This was explained by DeFabro in 2014 within a cancer pain context. It's often susceptible to poorly treated pain with somatization and depression, and particularly in terms of pharmacological tolerance and healthcare providers' ambivalence towards therapeutic needs. So we have this spectrum of aberrant, problematic drug use behaviors and risks, from pseudo-addiction through to chemical coping and through to addiction, with risk characteristics for both. QScript, this is based upon what was going to be happening in Queensland with the introduction of real-time prescription monitoring, and Nicolette is here to answer specific questions about that. What we need to know is that the major advantages of tracking opioid prescribing are fantastic, but potentially we may see an increased risk of refusal of dispensing an appropriate prescription. This is one of the concerns being expressed by my colleagues in palliative care, who say that patients with palliative care needs for opioids will certainly be ticking all the boxes to have a red alert for the prescribing. We don't want those individuals not given their opioids, and I don't want the same to happen in patients in persistent pain who are taking these medications. We try not to continue them, but we have to accept that there are patients who are coming to us already on these medications and also taking large doses. Because what we don't want is unplanned or unsupported withdrawal, and we don't want to encourage patients to shift to black market or illicit sources of their medications to treat their pain. We also need to understand it can increase the risk of opioid-related deaths, of polypharmacy, and also major reductions in quality of life. The recent article by Agnoli from the University of California in Sacramento has shown that opioid dose tapering by more than 10% a month has a very positive relationship with increased risk of overdoses and mental health crises. So we need to manage opioid reduction incredibly carefully and very sensitively. And with that, I'm going to end, and we'll move on to Ian's talk, and then I'll take questions.
Thank you for joining me today, and thank you for your invitation to speak on this topic. Tony has already spoken, and I will continue the story. Before I start, we acknowledge the traditional owners of this land on which this event takes place and pay respect to elders past and present. Tony has done the hard work. Let's talk about working with patients with chronic pain. Like heart and lung disease, diabetes and cancer, every person has the right to be treated, even chronic pain. In 2010, the International Association for the Study of Pain made a statement. It was the Declaration of Montreal, and it says, "Access to pain is a fundamental human right." The World Health Organization estimated 5 billion people live in countries with no or insufficient access to treatment for moderate to severe pain, and everyone should be entitled to treatment to acute pain. Chronic pain is a chronic health problem, and like diabetes or heart disease, should be managed as a chronic disease. Chronic pain is pain that continues beyond the normal expected time of healing. It is complex. Biologically speaking, it might be inflammatory, autoimmune, mechanical, neuropathic. Neurobiologically speaking, it might be nociplastic, that is, pain due to neuroplastic changes in the nervous system. Chronic pain is classified as nociceptive, neuropathic, and/or nociplastic. Nociceptive pain is somatic pain. It might be opioid responsive, but not always. In contrast, we rarely consider opioids or neuropathic pain for neuropathic or nociplastic pain. If pain was easy to treat, I would be out of a job. Chronic pain is a complex web of biomedical, psychological, social, and environmental factors. Then add to this human nature and nurture. These determine an individual's response to pain and how much one suffers. Tony has outlined the various dependence diagnoses. Some chronic pain patients have physical dependence. The drug reduces the pain and there is measurable improvement. There is a small subset of patients with psychological dependence and a smaller subset of patients with chronic pain and substance use disorder. The majority of chronic pain patients use prescribed medications appropriately and compliantly. One of our roles at the pain clinic is to assist managing the outliers. Let's look at this recent case. This 45-year-old woman is a 10-year survivor of breast cancer. She has had an extensive surgical history, chemotherapy and radiotherapy, and is on long-term treatment. There is persistent pain, scar hypersensitivity, neuropathic pain due to nerve damage, pain due to the surgery and physiological changes, chemotherapy-related neuropathic pain, and neuropathy and nociplastic pain. She's been taking a moderate stable dose of opiates for 10 years, OMED 60 milligrams, and still requires the occasional oxycodone IR for breakthrough pain. Side effects prohibit pregabalin. Anti-epileptics and tricyclics were ineffective. Her antidepressant is fluoxetine. Her sleep is poor, disturbed by the constant neuropathic pain. Unable to work, there is financial stress, and she worries for the children and their future, and being an adequate mother and wife. This is physical dependence. Without the opiate, she would not be able to function or care for her family. Most would agree this is appropriate and would not label her as a drug-dependent person. But what would you say if the story was slightly different? A smoker, history of past alcohol use, and experimented with illicit drugs in her teens. She could be isolated, no social support, lives in the bush. All these things matter, and they do not equate to substance use disorder. As you can see, there are many factors to consider managing a person with legitimate pain, and many more if the pain seems unbelievable or unresponsive to standard treatments. How do we determine the therapy for a patient with chronic pain? A comprehensive history is essential. We need to understand the nature of the pain, the cause and contributing factors. What treatments have been tried and what the current treatments are, and if they are appropriate. We explore psychological health and ideology. Beliefs and expectations affect outcomes. The social history is part of the assessment. Education and health literacy affect treatment choices. Then there might be home stress or prejudice. We work towards establishing a therapeutic rapport. We need this to discuss worries, fears, and changes to therapy. Our goals are always appropriate therapy, minimize harm, rehabilitation pain management, maximize function, independence, and quality of life. We will often review and rationalize the medications. So what about dependence? Tony has spoken about this before. Physical dependence means a person uses a medication as prescribed and demonstrates benefit. But if the dose keeps increasing, ask yourself, is this tolerance? Is it appropriate? Is it effective? Should it continue? As a general rule, if there is no analgesia at an oral morphine equivalence of 100 milligrams, then an opioid is not the right choice. You should be thinking about this at an OMED of 60 milligrams. Psychological dependence might be exposed by questioning or asking these questions. How do you feel when you take it? Or when do you feel you need to take more pain relief? Those who take opiates for anxiety is a leftover from the Bex and benzo days. Some papers do find opiates ease anxiety. That is because it's an anxiolytic. Or they need to ease withdrawal symptoms, or they're afraid of withdrawal. Opioids are not the best choice for anxiety. Preparing to ask about illicit drugs has been made easier since the introduction of medicinal cannabis. So start asking about medicinal cannabis. There are currently 10,000 requests to prescribe medicinal cannabis each month in Australia. Yet I rarely find someone who obtains pain relief from cannabis. The most they report is feeling more calm, relaxed, and sleeping better. From this point, you might ask, have you tried alcohol to manage the pain? Because some people do. Or you might ask next about illicit drugs for pain, or perhaps other reasons. Misuse is open to interpretation. Tony described pseudoaddiction, and this describes when a patient is given a subtherapeutic dose of analgesia, and their pain management stabilizes as soon as the correct dose is given. But be warned, there is always a risk of trying higher doses. As a general rule, 2 increments, 2 classes of opioids will determine if an opioid is correct. And remember, each opioid has a different potency, so it's not simply try a different drug. Misuse means taking more than prescribed or inappropriately or against medical advice. Be careful not to judge too unfairly. We all have a small stash of paracetamol or Nurofen at home, just in case, and I bet you will take it for a headache without first seeking medical advice. Substance use disorder in chronic pain patients does coexist, infrequently, but it happens. They tend to use higher doses, ask for higher doses, ask specific drugs, and misuse, and even after they're told about the risks and harm. The pain clinics are tasked to assist when there is both chronic pain and substance use disorder. But this can be awkward. Opiate substitution therapy is not pain management, and there are laws to protect the patients from this. As Mr. Hall also explained, it is not just opiates we worry about. Benzos, gabapentinoids, Z drugs, antipsychotics, their misuse is concerning. In fact, any drug misused is a worry. I had one case when the patient used thyroxine to lose weight. Chronic pain management is individualized. Appropriate treatment is not determined by the condition or the patient's size or shape or circumstances. Once you feel you are helping manage the pain, use the 5 A's to review routinely. Is the medication providing real analgesia? Are there side effects? Does it improve function? Is there any concerning use? And always ask yourself, is it the right dose? Could it be reduced? Could they manage with less? Set an oral morphine equivalence dose of 60 milligrams as your threshold to consider the drug as too much or inappropriate. If this dose isn't working, ask yourself, is it the right drug or should it be used at all? It is much easier to wean someone who is on a low dose and prepared to wean. It is very hard to wean someone on high doses with long-term use and embedded belief and expectations. Any analgesic trial starts with a discussion about benefits, risks, and weaning if ineffective. This is before the first prescription. Misuse and aberrant use is hard to define or prove if the patient is not known to MMU or flagged in prescription shopping program. Can I say, a dispense history is more accurate than the prescription program, and I will talk again briefly about this because this is what the real-time monitoring system is. We routinely perform an informal, sometimes formal, mental state examination. Appearance, language, behavior, thoughts, expectations, beliefs reveal a lot about a patient, their potential medication use or misuse, and the therapeutic beliefs. Never, and I say never, be ashamed to ask for advice or another's opinion. It is why consultants are given phones. Always ask for assistance if you feel uncertain or confronted by a situation or feel uncomfortable managing a patient. Some patients are just challenging. When it is particularly difficult, patient at the pain clinic, I will sometimes co-interview with another consultant, and I am always prepared to ask for another opinion. Telehealth and case conferencing has opened this strategy to everyone. The other part we do as part of our assessment is review the clinical notes, reports, scans, and checks. That's with MMU, prescription shopping, anyone else. SEMA is useful. Checks help us define and provide comprehensive treatment. When the clinical care is sorted, what next? What other strategies are available to keep a person safe? I'm showing you this graph, which Tony also presented, because it shows a downward trend from 2016. This is when pain management education started to become a priority. This is the value of workshops, GP education sessions, case conferencing. And sorry, I cannot explain the Western Australia trend, but they are out west, of course. Another strategy introduced was taking codeine off the shelf, and this has been proven very effective. The Opioid Stewardship Program has just been introduced and is widespread throughout Queensland. And it's proving particularly useful in the acute pain setting. The next educational step in pain management is training for undergraduates, GPs in training, junior and senior doctors in hospitals, and a good educational program. What else has the government been doing? Let's get to real-time monitoring of prescriptions. This is a Commonwealth and state initiative, and it was to address the concerns about drugs with substance use disorder, drugs that have potential risk and addiction. Some states aren't there yet, but there are certainly three have established system, and Queensland is about to start. Queensland's real-time monitoring program is due to start soon and will bring promise sometime in the next couple of months. The value of this program is doctors will be required to check before providing a script, and will be able to see if a script has been recently dispensed or issued. The pharmacist is required to check before dispensing any drug of dependence. It's the second protective factor. This will reduce oversupply of risk medications and reduce stockpiling. I'm sorry, no more Christmas stocking fillers, and they won't be able to stockpile once their their prescriptions have gone to free. It is hoped it will reduce overdose deaths and prescription deaths. It is not a comprehensive program and there are still problems with it, but it's still valuable. And so all clinicians must stay vigilant. In summary, everyone has the right to good pain management. It is a world problem and should not be a first world problem. Equal access to healthcare means breaking down the social barriers, no matter where you live or where you are from. Equity means investing in services and technology. As health professionals, we are expected to provide comprehensive and good healthcare to all, including those with chronic pain. Good healthcare is evidence-based and research should be encouraged. Education is for everyone, clinicians and patients. It breaks down the barriers in the delivery of good care. Everyone, including the patient, are responsible for the safe use of medications, especially S8s and drugs of dependence. Thank you. If you have any questions, ask Tony now or contact me at the Pain Clinic.
Well, thank you very much, both to Dr. Ian Thong then, who was presenting to us from his pre-recorded message today, and also Tony. And Tony, you're online there. I know your camera's off at the moment and your mic's off, so feel free to come back and join us. We do have a few questions that have come through, and we'll refer to those now. We're aware of the time some people may need to leave us. But between yourselves and possibly also for you, Nicolette, we've had a few questions come through around, you know, some of those difficult conversations that people might need to be having just in practice normally, but may also be prompted by some of the I guess the impacts with QScript coming in, where patients may have particular strong beliefs about these medications and the benefits they obtain from them. Am I correct, Nicolette? You may be able to speak to this a bit more, that in the QScript Learning site, which we're going to pop in the chat in a few moments, the link to, that there is some trainings and some e-learnings around those types of clinical scenarios.
Yeah, there certainly is a lot of information that we tried to address around those more challenging conversations or honest conversations that we do have with patients. And I think one of the key messages that we're trying to get through is that abruptly ceasing or rapidly tapering, like Tony is saying, is contrary to patient safety. And sometimes you are put in that difficult situation of continuing an opioid therapy for someone with chronic pain, and that might be in the best interest of that patient in their care, and only the health practitioner can make that decision. QScript can just provide you with information, and I think the individual care is where the health practitioner sort of weighs up all of those things that are happening. In our next webinar that we have next week, we'll be breaking down a case study as well of one of those particularly challenging scenarios, and we'll have a panel of experts which will answer some of those questions. And I think one of the other things that I would encourage people to do is talk with their colleagues and talk about, you know, these challenging conversations. Use your colleagues to discuss these scenarios and see if there is other options that you can come up with. And always we want to make sure that the patient is the centre of care and they're engaged in treatment, because we know that there's more risks with them not being engaged in treatment. So That's the messaging we're trying to drive with QScript, that it is a system that provides you with prescription histories, but the information, it can't dictate care or the individual needs of that patient.
No, great. Thanks, Nicolette. And we will be popping into the chat the link to that QScript website, which has a number of trainings on it around and demonstrations of these types of conversations. But Tony, I guess, as you say, you have these types of conversations every day. Just interested to know from your experience in one of our attendees has asked that question around how, some of the ways that you found, I guess, that has been effective to help people maybe develop alternate perspectives to where medication is not necessarily the most effective thing for them.
Well, I think the basis of much of my conversations is trying to be as honest as we possibly can and explain what drugs can do and what they can't do. And then get the patient to reflect on their experience regarding that sort of expectations. I come across patients, they've had bigger doses and their pain is certainly no better, no worse by taking those big doses when they were taking smaller. So we can use that as a means of explanation of why we want to reduce. I always think of describing medication use as a balance between the benefit and the side effect. And sometimes we need to just readjust that balance. And certainly the side effects of many of these medications are ones that patients often don't consider as being a side effect. I've seen lots of patients, for instance, taking a gabapentinoid that put on significant amount of body weight. And body weight for persistent pain is a real significant issue, because we have to move this body weight around with us, and that can increase pain. So the side effects of the gabapentinoids can often be the negative to the benefit that they might achieve. And the major intervention that's carried out in healthcare is that we start medications. We don't really stop very many medications. So there's a comment about the use of opioids in persistent pain. And yeah, I agree that we really do not want to start patients on opioids, but around about 90%, 100% of the patients who come to the clinic are already on them. They've been started by GPs, they've been continued by specialists in the hospital and in the community setting. And we now have to deal with this scenario where the patients are taking doses, and because traditional mechanisms of managing symptoms are, we increase dose. So I've seen patients who are on, supra maximal doses of gabapentinoids, for instance, which we know have no evidence in therapeutic use, where we're still seeing the doses increase because that's the only response the poor GP has. They don't have the time to spend with patients that we do. Most of my consultations are 45 minutes, and then I can always get the patient back again to continue that consultation if we haven't been able to finish. And for many patients, that we know is a need. Patients with, for instance, chronic widespread pain like fibromyalgia, they seem to require bigger doses of our treatment intervention, just interventions in terms of consultation. They need bigger doses because of the nature of their pain. They're, it's trying to get their head around the concept of sensitization as a feature of pain is something that they really struggle with, particularly when they also experience cognitive fogging, if you like, from the effect of the disease. So these patients often demand and require frequent sort of consultation just to touch base, to support and keep me moving people on. And they're going to be, they'll take 2 steps forward and then 1 step back, but at least we're getting to get some benefits coming into play. But these patients require often long-term intervention, and unfortunately, community practice cannot support individuals in that way.
No, understood. And I guess some of that goes back to what you mentioned in your part of the presentation, where that discussion about a goal and a plan and I guess a process of reviewing the progress.
That's exactly right. Ian mentioned the 5 A's, and we try to use those every time we see the patient. It's part of the structure of the interview, the consultation we have is we review that, we look for changes in those 5 A's before we make decisions about what we might do next.
Sure. And apart from some of the information that's been presented today, and this question comes, I guess, from the allied health side of things, is there any resources that you're aware of that are good ones for helping people, allied health clinicians, say as physiotherapists or other allied health clinicians, discuss pain or discuss pain medications?
There's not, no, not really. Physiotherapy has now a specialization process which can work towards the specialization within a persistent pain environment. So individuals who are lacking in that can seek input into their professional development from those specialists.
Right.
We're lucky enough to have Darren Doherty here in the clinic on the Gold Coast, one of those specialist physiotherapists. He still consults with me when it comes to medication, and I think that's the benefits we have of working we call it an interdisciplinary team. We each overlap in terms of our areas of specialty. I've been told I overlap with psychology. I don't see that as a negative. I think that's part of what we achieve as this interdisciplinary team, is that where we identify problems, we can speak to other people about them, and we have those close links within our clinic. Working as individuals, perhaps in community physiotherapy, it's hard to develop those. It's really then, and I have the same conversations with community pharmacists, that they're asked to speak about the medications, but without the other elements of input, it's a difficulty for them. So it's a question of starting to form those interdisciplinary teams within your environment. So go out and speak to each other. Don't just sit in your clinic thinking, I'm all on my own dealing with all these patients, these difficult patients. It's then, okay, well, now go out and speak to your community pharmacist, make that develop that relationship so you can talk to each other.
Yeah, no, good points there. I'm aware also that many may have either left or needing to leave because they have commitments and other parts to get to. Thank you for those who have hung around. There's just one more question, which I guess it could be an easy one or a big one, but current definitions of acute and chronic pain. I know Ian spoke to some of that, but just in terms of, I guess, for our audience, particularly out there in the alcohol and drug sector.
So acute pain is described as the nociceptive response to an actual or potential body damage. We go to the dentist, we'll have a tooth pulled. We experience pain going into the dentist because we're developing the abscess, and then we may have pain after the procedure because they've had to remove the tooth. That would be followed by a healing process in almost all circumstances, and that healing would be considered completed within 3 months. Persistent pain is described as pain in the absence of that healing. After that healing process would be expected to have finished. So we usually describe persistent pain as developing at 3 months and for longer. And then you've also got as a subacute as well. Chronic back pain, it's going to be painful perhaps for 2 or 3 weeks after the initial injury, and I say injury in parentheses, and then we can then have recurrent flares of that. We return to work and we still have to bend down, lift up things, and we can then get a flare of those injuries. We class that as subacute.
No, great. No, thank you. Thank you very much. Sorry.
And you can also get acute on the chronic as well, is that in our chronic pain patients, we commonly see patients who are experiencing acute flares because pain is a universal experience. And just because you've got chronic pain doesn't mean that you're going to be exempt from those acute pains as well.